Hello, my name is Michael Feldman. I'm the medical director of the Evans-Haynes Burn Center, which is part of the Virginia Commonwealth University in Richmond, Virginia. It is my honor to be the course director for the burn course for the Panamerican Trauma Society, and we look forward to educating folks on burn treatment. This is part of a series of lectures that we hope will help with your practice and make you more informed about burn patients in general. This is a discussion about burn resuscitation, and it is my pleasure to introduce you to this topic. Learning points for this discussion include a review of the history of burn resuscitation, learning about current burn resuscitation recommendations, as well as those who are considered non-responders, i.e., how to treat those who don't respond to the typical resuscitation approach, and then learning how to implement these in your practice. Burn resuscitation was initially identified by Underhill and Moore in the 1930s and 40s. There they recognized that thermal injury induced intravascular fluid deficits. Here we see a picture of the Coconut Grove fire. This was a horrible building fire where many hundreds of patients died either on site or after getting to the hospital, and taught practitioners many lessons about treating burns. I want to draw your attention to the layout of the Coconut Grove lounge. You can see that there weren't that many entry and exit points, and that they had blocked some to make sure that patrons paid. This was a setup that unfortunately caused many hundreds of patients to die either on scene from flame or even later secondary to the inhalation injury. This led to modern legislation that helps protect patrons in clubs and lounges and other buildings where there need to be multiple entry and exit points, and you can't bar these doors. Many of the points that we know now as modern burn resuscitation, as late as the 1970s, a 30% burn was associated with nearly 100% mortality. The older you were, the more likely you were to die. These lessons were learned in the Coconut Grove fire in 1942, as well as the Rialto fire from 1921. What we came to know was that resuscitation is increased as the body surface area involvement of burn is increased. Now, this is only second and third degree burn involvement, not first degree. It is possible to give too much fluid, and we'll get into that later. Burn patients require resuscitation at a steady pace. The fluid lost from your burn is not suddenly dumped out, it is slowly leaked over time. So we give it back over time, and it's an adjustment up or down based on signs that you're perfusing end organs. We also know that the presence or absence of inhalation will adjust how much fluid patients need. In this slide, you can see that burn physiology has some specific effects on the body. It can reduce cardiac output as well as increase capillary leakage. This capillary leakage occurs mostly in the first 8 hours after a burn. Therefore, giving albumin-rich products early in a burn is contraindicated, as this may worsen edema, compartment syndrome, and pulmonary or cardiac overload. It's important to be accurate with total body surface area, as the amount of fluid you're giving is dependent upon an accurate estimation of second and third degree burns. The use of a resuscitation formula is a starting point, but it's not that one size fits all. The resuscitation formula is merely a point at which one starts and then adjusts based on signs of perfusion. In most points, that's urine output. It's quite easy to get a hold of, to track hourly, and a cheap method is to insert a Foley. Dr. Saffel talked about his approach to crystalloid, which we've adapted in our own resuscitation guideline, which I'll show you later, and introduced an albumin rescue for those who are non-responders. We'll approach that later in the talk. Dr. Pruitt discusses fluid creep. This is a concept where modern burn resuscitation has led to a more excessive use of fluids, and it is a slow, steady increase that eventually leads to edema, compartment syndrome, and increased mortality. Dr. Pruitt hypothesized that this may be related to multiple issues, including a failure to reduce the rate when urine output is adequate, an increased use of opioids, which can cause vasodilation, resuscitating based on a different endpoint, such as lactate or blood pressure, as opposed to urine output, and a failure to recognize the non-responder. In other words, the additional use of fluid when it's not working. Over-resuscitation can lead to some pretty horrible outcomes. In this case, there was a patient who had a less than 10% burn, who got multiple liters of fluid within several hours and presented unable to ventilate or oxygenate on multiple pressors. This wasn't due to trauma or the burn, it was due to over-resuscitation. The answer is to perform an exploratory laparotomy and to release the compartment of the abdomen and leave it open. Unfortunately, in situations like this, the mortality is quite high when this occurs. There are some burn centers which use additional tools for resuscitation. These can include plasma exchange, the addition of colloids, as we'll discuss in a rescue formula, as well as valproic acid. While there is not one approach to any burn resuscitation, there are those who will bring these in to patients who are not responding, or they'll use them in large surface area burns initially. We know that there is not a routine role for the use of blood products, especially packed red blood cells, in the resuscitation of burn patients. One would want to avoid the routine use of blood products, especially in the first 8 or 12 hours or so after a large burn, due to the presence of capillary leakage. We also knew, due to the work of Dr. Palmieri and her group, that burn patients can tolerate a low hemoglobin. Keep in mind that increased use of blood products will increase infection, and that hemoglobin itself is not a reliable measure of total blood volume. The use of blood products should be reserved for burn patients who have additional trauma that may have caused a large amount of blood loss early on, or those with coagulopathies that can't be corrected in any other way. This slide shows our approach to adult burn patients with large burns, 20% or greater total body surface area, second and third degree burns only. Keep in mind you would want to avoid the use of resuscitation with first degree burns. We choose to start with a consensus formula resuscitation that's using 3 mLs per total body surface area and weight in kilograms. Now this gives you fluids for 24 hours, which can be adjusted based on multiple parameters. The fluid is divided in 2, and then the first half is given over 8 hours if the patient arrives to you very quickly after the burn. Let's say they arrive 2 hours after the burn, then you would give the first half of that fluid over 6 hours instead of 8 hours. Once you calculate the total body surface area, measure their weight, multiply all this together, keeping in mind that the total body surface area is the whole number, not the percent. So you would multiply by 30 for a 30% burn as opposed to 0.3. Once this rate is measured, you titrate based on urine output. So if the urine output is 30 to 50, we leave the rate where it is. If it's less than that, we go up by 10% or 20%. If it's greater than that, we go down by 10% or 20%. As previously noted, we adjust the rate of the crystalloid based on urine output. Here I've highlighted where the urine output is either too low, meaning less than 30 mLs per hour, or too high, being greater than 50 mLs per hour. Where the fluid is less than 15 mLs, where the urine output is less than 15 mLs, we'll go up by 20%. Where the urine output is 15 to 29 mLs, we'll only go up by 10%. If the urine output is 51 to 150 mLs per hour, we'll come down by 10%, and where the urine output is greater than 150, we'll come down by 20%. As previously noted, it is as important to come down on the fluid rate as it is to go up on the fluid rate. You'll notice that this guideline also states that you have to raise awareness that the patient is not making urine output for any hour, or if they have to go up on fluids for any 2 consecutive hours, as this points to a patient who may be becoming a non-responder. For those who aren't responders, and they're 8 hours or more out from their injury, we adopt a method of ruling out things that may have been missed. For example, other trauma or an inhalation injury. We'll make sure that their weight is accurate and their total body surface area is accurate. If this is the case, and it's 8 hours or more after the burn injury, we'll start them on an albumin drip at 1 ml per kg in weight. This is converted into 5% albumin that's subtracted from their total crystalloid rate. The albumin is not adjusted in the remaining 24-hour resuscitation, but the crystalloid is. We use lactated ringers for our crystalloid as opposed to normal saline, as large volume normal saline resuscitation can lead to a metabolic acidosis. For patients who don't respond to albumin and crystalloid and are approaching a point of no return, instead of letting them develop a compartment syndrome, we will consider early dialysis. It may be helpful to check bladder pressures every 4 hours in these patients, as this can show you when you're approaching that point of no return. Keep in mind, in large burns, sometimes early excision is the answer to help reduce that inflammatory response to the large burn and help improve their outcome. There have been studies that show that mediators of increased vascularity are cysteinoleukotrienes. Cysteinoleukotrienes have been noted to be potent mediators of inflammation that increase vascular permeability. This may also be due to other mediators such as tumor necrosis factor alpha or interleukins 1 and 6. Both 1 and 6 have been implicated in SIRS response, and IL-6 is a marker for poor outcomes. It may be that in the future we can block the action of these cysteinoleukotrienes or TNF-alpha or IL-1 and 6 and hopefully reduce the effects of capillary leakage on outcomes. Next, we are going to review methods that determine total body surface area. As I have previously mentioned, this is extremely important to figuring out how much fluid a burn patient requires, as well as their expected mortality. There are multiple methods for determining total body surface area. We will review the rule of nines, the palm method, the London-Browder chart, and the SAGE diagram, as each of these has a pro and a con to their use. Be reviewed. This is the London-Browder. This was initially conceived by Drs. Lund and Browder after the Coconut Grove fire. You can see that it divides up the body into multiple specific parts and assigns a total body surface area to each of these. For example, in an adult circumferential arm from fingertips to shoulder, it's 9%. So if a portion of that is injured, the percent involvement would be adjusted as appropriate. For example, if half of the circumferential extremity was involved, you would assign it 4.5%. You can see that with age, the ratio of size in total body surface area changes. For example, the head represents a much larger area of the body in children than it does in adults. This is the SAGE diagram. It's an online flash-based program where a two-dimensional image of the patient can be used, and the user draws on this image and it calculates total body surface area and helps with fluid resuscitation. Folks may not always have access to these resources, in which case the rule of palms can be helpful in smaller burns. The patient's palm plus fingers held together is 1% of the patient's body. In larger burns, the rule of nines may be helpful. The body parts are divisible by 9. So as previously mentioned, the upper extremities from fingertips to shoulder are 9% circumferentially. The lower extremities from the tips of the toes to the hip joints are 18% each. The anterior trunk is 18%. The posterior trunk is 18%. From the neck up to the scalp, circumferentially is 9%, and the genitalia and perineum are assigned 1%. This all adds up to 100% and can be a faster method for determining total body surface area in patients with larger burns. Next, we'll review inhalation injury and its relationship to fluid resuscitation. Here you can see a bronchoscopic examination showing the presence of soot and erythema of the mucosa and quite extensive inhalation injury. Those with significant inhalation injury will require additional fluid beyond what is predicted by the burn formula. It also increases mortality and adds another 17 years to the Bow formula. The Bow formula is age plus total body surface area, burn involvement, second and third degree in particular, equals mortality. And we'll get into the updated Bow formula in the next slide. For those who have a significant inhalation injury, we treat them with every 4 hours alternating nebulized albuterol, heparin, and mucomist, as well as 100% oxygen for 6 hours. These patients don't always require intubation, but you should have a low threshold to secure their airway, as it can be quite difficult to do so in an emergent situation. We'll treat carboxyhemoglobin levels with 100% oxygen, but we'll give the cyanokit, which is a vitamin B12 derivative, as a method to treat potential cyanide exposure. Most everything that burns in modern enclosures creates cyanide as a byproduct of incomplete combustion. This is the updated Bow score, showing you that the relationship between age, total body surface area, and mortality is no longer a 1-to-1 ratio. With improved critical care and surgical care, survival is possible up to a Bow score of 150. The presence of inhalation can add about 17 years to this mortality formula. We'll finish up this lecture with a discussion of several methods on how to improve outcome for patients with burns. Here we're showing you a patient who's been treated with a cyanokit, which can stain all fluids, including mucosal surfaces and wounds, with a deep purple color. This is an effective method to avoid the effects of cyanide. As previously mentioned, this should be given as soon as possible to a patient who's been in an enclosed area where flame exposure has occurred. Keep your patient warm. Hypothermia has been shown to affect all systems of the body. This can be cardiac output, coagulopathy, even the immune system is reduced in patients who are hypothermic. We'll go to many lengths to keep the patient warm. Here we have warm forced air, blankets, underbody warmer, as well as heat lamps. Keep in mind that fluid resuscitation is a marathon, not a sprint, and that one should be prepared to keep track of the patient every hour, that they should have a dedicated group of burn practitioners who are familiar with the guidelines. Oftentimes in large burns, you require an early excision and surgical approach to help improve survival. Thank you for listening to this discussion, and we look forward to additional talks. Thank you very much.